The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to the webinar and update on Missouri laws and regulations. I am Annie Eisenbeis, a pharmacist, Stillcop alum, and currently the Executive Fellow for the Missouri Pharmacy Association. I have no personal or financial conflicts of interest to disclose, and my objectives include the following: describe recent pharmacy-related legislative updates in Missouri, discuss potential 2019 legislative agenda for the profession of pharmacy, and identify ways to get involved in advocating for pharmacy and patients. Politics is overwhelming, so how do I make my voice heard? Well, you can't know where you're going unless you know where you've been, so let's start by looking at this past year's legislation. Senate Bill 826 was a big win for pharmacists. It was signed into law by Governor Mike Parson in Springfield, Missouri, at an independent pharmacy called Alps Pharmacy, owned by MPA past President Melody Savely. Several pharmacists from around the area were also in attendance, as well as legislators and other pharmacy and healthcare leaders. It was quite an exciting day. We'll also go over Missouri Board of Pharmacy rule changes. So first on the agenda for Senate Bill 826 was controlled substances. So an initial prescription for acute pain opioid script now has a 7-day limit. This applies to opioids only. So what is an initial prescription? It's a prescription the patient has never been issued for the drug or has not used or been prescribed or administered the medication within 5 months prior to the current script. And what is acute pain? Pain that the practitioner reasonably expects to last only a short period of time. It does not include chronic pain, pain being treated as part of cancer care, hospice, or other end-of-life care, or medication-assisted treatment for substance use disorders. How do you know? So making a good faith effort and asking the customer or the prescriber, so keeping that open line of communication. Check your pharmacy records, and of course document your efforts, because if you didn't document it, you didn't do it. Exemptions from this limit include cancer treatment, palliative care, hospice care, long-term care facilities, treatment for substance abuse or opioid dependence, prescriber, and if the prescriber deems the medication medically necessary for longer than the limit. The Board of Pharmacy also has a presentation or webinar that gets into more detail about this, so if you have any questions about that, you can refer to that or ask me for that information. We also are now allowed to collect unused controlled substance medications through drug take-back collection receptacles, drug disposal boxes, or other means provided through drug take-back programs by a DEA authorized collector, even if the authorized collector did not originally dispense the drug. So Chapter 195 now allows drug take-back. However, you do still need to comply with federal requirements. This is assisting the fight against the opioid epidemic by helping get unused controlled substances out of patients' homes and prepped for destruction. And the most recent Board of Pharmacy meeting, they did discuss take-back kind of funding available through the board, and that's still in discussion, so they didn't really come up with an answer yet, but they're debating whether they are going to provide funding to pharmacies or kind of placing drug disposal boxes at various sites so that the Board of Pharmacy can also increase patient safety in the communities. As a side note, I mentioned Chapter 195. This defines drug relations and contains the Narcotic Drug Act, which includes laws pertaining to controlled substances. So if ever you see 195 point number, that is about controlled substance laws and regulations. You may hear also reference to Chapter 338, which is the laws pertaining to pharmacists and pharmacies, and include the Pharmacy Practice Act, which regulates our scope of practice, so what we can and can't do as pharmacists. Speaking of what we can do now, the vaccine age restriction has decreased from 12 to 7 years old for written protocol vaccines or per CDC recommendations, whichever is higher. You do want to check your protocol to make sure that the lowered age is allowed. So in the bigger picture, the increased access to care and preventative health care for patients, especially in medically underserved areas. And although I'm preaching to the choir, we are the most accessible healthcare professionals. And this slide just serves as a reminder of how far pharmacists and legislation for pharmacists has come. So being able to provide these vaccines per protocol is not only a big win for public health initiatives and better access to vaccines, but for pharmacists being able to administer these vaccines, that's pretty great. We also now have the ShowMe Vax system in our regulations. So what is ShowMe Vax? It's Missouri's statewide immunization registry operated by the Department of Health and Senior Services. According to the Senate Bill 826, all vaccines must be reported to ShowMe Vax unless the patient opts out of reporting. So you do need to gather informed patient consent. Most pharmacies have been adding kind of like a checkbox for patients to opt out of the ShowMe Vax system. In which case, if the patient refuses, you'll have 14 days to notify the primary care physician of the vaccine administration. With ShowMe Vax, you can either upload vaccine data directly from the pharmacy technology system or a reporting service, so kind of an automatic reporting system, or you can manually enter the information online using the ShowMe Vax website. And if you're doing that, you do need to use Internet Explorer through a Windows PC. It's required to report online manually, so you can't use any other web browser. Our first learning assessment question: what immunization age restriction did the Senate Bill 826 lower to? Was it A, it went from 12 to 7 or CDC guidelines? B, the restriction was eliminated? C, the restriction did not change? Or D, it went from 12 to 15 or CDC guidelines? The answer is A as in apple. The restriction went from age 12 to age 7 or CDC guidelines, whichever is higher. And that is per that Senate Bill 826 that pharmacists fought for. We also now have two-line format no longer required for prescription pads, with dispenses written on the right and substitution permitted on the left. But can you still fill a two-line format prescription? The answer is yes. Out-of-state prescriptions do still have to comply with applicable state law, and the generic substitution is allowed unless the patient requests a brand name or biological product. So like DAW2, the patient requests the brand name. The prescriber indicates the substitution is prohibited in some manner. So whether they write DAW, do not substitute, brand medically necessary, something on the prescription. And it must be less expensive. We also had a start with our pharmacy benefit managers, the PBMs, and kind of increasing transparency. So the bill eliminated the gag clause of PBM contracts with pharmacies. It now allows you to tell your patients that there is a cheaper cash price available without running the prescription through their insurance. And then DIR fees and clawbacks have been limited, so you'll now be aware of any additional fees at the time of the claims adjudication. This will be enforced by the Department of Insurance, Financial Institutions, and Professional Registration. Note, this only applies to state-based plans and not to Medicare Part D plans, unfortunately. I did quickly go into what DIR fees and clawbacks are. So DIR fees are fees that the pharmacies may see PBMs charge outside of the administration fees and are generally collected after the point of sale. So we see them in several forms. Originally, DIR fees were more commonly seen via reconciliation between the claim and the negotiated price. Also, another common DIR fee that we see is when a pharmacy would pay the PBM in order to participate in a preferred network or a pay-to-play. At times, the fee is based on the performance of the pharmacy, meaning that the PBM can take money back from the pharmacy and create a situation where the pharmacy does not receive adequate reimbursement to cover its costs due to arbitrary performance standards that frequently serve as a moving goalpost. Hence, the DIR is now seen as a catch-all, so it's been expanded well beyond the CMS's intended use of its definition. And like I said, sometimes it causes a situation where the pharmacies lose money on filling a prescription because the reimbursement doesn't even cover the cost of that drug. And what is a clawback? So most insured patients assume their copay is a discount from the full drug price, but that's not always so. So what happens if the negotiated price is less than the copay? Much of that is passed by the pharmacy back to the PBM as a clawback. So things we do not like. There were several Missouri Board of Pharmacy rule changes. I just highlighted 3 of them here. No, you're no longer required to include to be administered by a pharmacist on vaccine administration prescriptions. You do not have to do the annual review of policy and procedure manuals. That's no longer required. However, you still need to comply with those policy and procedures that are in those manuals. So I personally am still going to most likely do an annual review just as my own kind of update on my policies and procedures. And then the primary care physician must be notified within 14 days of administering a vaccine, and they must be notified within 24 hours of an adverse event or reaction. So that 14 days is just if the patient opts out of the ShowMe Vax system. Looking at the 2019 legislative session, we have the PDMP, or Prescription Drug Monitoring Program. Medicaid, which is thinking about going from from fee-for-service to managed care. So we'll talk about both of those options. And then roles and responsibilities of pharmacy technicians has come up a lot. I don't have a slide for this one, but I just wanted to mention that it's come up in discussions with the Board of Pharmacy, as well as several organizations and associations kind of discussing when the pharmacist scope of practice or our scope is expanding and we want it to expand, how does that then correlate to technicians who are assisting us? So it kind of brought into light or discussions with remote supervision, tech, and the changing roles being discussed at the Board of Pharmacy level, like I said. So first we'll talk about the Prescription Drug Monitoring Program. We are the last state without one, so that includes Guam and Puerto Rico. We are supporting legislation for statewide PDMP because currently we just have certain counties with prescription drug monitoring programs and other counties without, so they're not able to submit information to those PDMPs. They can only look at the information, which is still better than nothing, but the effort for the PDMP, the reason we are the only state without one is because our efforts to push a statewide PDMP have been thwarted in the past by a senator who would filibuster the bill every year and not allow it to pass, citing concerns about Big Brother. So he didn't want everyone to be able to see your medical information, even though that's not technically the case. And then this is only a step in the fight against the opioid epidemic, so it's kind of a very small step, but it will help pharmacies a lot. And then on the national front, just so you're aware, NCPDP is drafting potential legislation for a nationwide database and monitoring program. So look out for more information on that coming up on the horizon. Kind of a complicated but very, very important subject is Medicaid. So we want pharmacy to remain what we call carved out and not included in the managed care organizations and continue with the fee-for-service model for pharmacy. So with that being said, some states offer Medicaid benefits with fee-for-service through managed care plans or both. Under the fee-for-service model, which pharmacy is under right now, the state pays providers directly for each covered service received by a Medicaid beneficiary. Under managed care, the state pays a fee to a managed care plan for each person enrolled in the plan, and then that managed care plan determines the pricing and payment given to the pharmacy for that covered service. For fee-for-service, in general, states set provider payments under fee-for-service consistent with efficiency, economy, quality of care, and sufficient to provide access equivalent to the general population. So advocates of fee-for-service accuse managed care of withholding effective treatments and healthcare interventions to save money or build profits. In turn, advocates of managed care, and this is really important, they claim that fee-for-service squanders money on treatments. So when you're talking about really high pharmacy payments and money going towards pharmacy, that's a really big push in legislation to bring that money down. But in turn, they say that the treatments that generate fees but no quality and claim that they can save the state a lot of money through tighter management of healthcare. But just recently, the state of Ohio, whose pharmacy contracts were through PBMs and managed care initially, had growing concerns about declining reimbursements to independent community pharmacies. So they asked their auditor of the state to independently analyze certain issues, and they found a lack of transparent data on pharmacy services, a disconnect between pharmacy reimbursement and overall costs to the Medicaid program. So we call that spread pricing, where the pharmacies weren't being reimbursed, but the costs were still going up and very high. Potential conflicts of interest related to a retail pharmacy chain that's affiliated with one of the PBMs, and reported reductions in pharmacy reimbursements outside of that chain. The impact of reductions in pharmacy reimbursement on access to care, particularly in rural communities, was very big. So they're actually reviewing in Ohio the pharmacy payment data related to that Medicaid managed care program, and we will see what happens, but so far they are not happy with the program. All right, so my next learning assessment question: how do we attain provider status? A, update the Pharmacy Practice Act or scope of practice. B, legislation. C, reimbursement. Or D, all of the above. The answer is D as in dog, all of the above, and let's talk about why. We want to be recognized as providers, but there's so much more to it. So every state kind of has their own definition of provider status, and the nation has its own definition. But what we really need to ultimately do is change the Pharmacy Practice Act, so that Chapter 338 of the Missouri statutes that I mentioned earlier. And we need to update it to reflect what we want to be able to do as pharmacists to provide better and more accessible care to our patients. So with reimbursement, with reimbursement, if we perform clinical interventions outside of the dispensing role, we want to be able to bill for it. So with the government reimbursements, that's through Medicare and Medicaid, and with private payers, either through legislation or through direct communication with those payers. We just want to be able to get paid for what were our clinical interventions. So federal status versus state status. We have federal status, so we want to be able to bill Medicare Part B as in boy, which includes the medical billing realm, so something that most pharmacists are not super aware about, but that would be a really big win. And then the state status, to be able to bill Medicaid and state government employees' healthcare plans. Next learning assessment question: name one way a pharmacist can be heard on issues relating to policy for pharmacists and patients. A, get involved in your state pharmacy association. B, contact and communicate regularly with your legislator. C, attend Board of Pharmacy meetings. Or D, all of the above. The answer is D, all of the above. If you didn't know, D is for dog, and dogs are my favorite animal, so I happen to pick D a lot. But let's talk about it on the next slide. So getting involved with your state association, like Missouri Pharmacy Association or MSHP, you can become a committee member. So with MPA, we have 4 committees that include membership, legislation, professional affairs, and the CE or continuing education committee, which most pharmacy associations have similar committees. So if you're interested in anything like that, or any of those particular committees strike your fancy, you can contact whatever association or organization you want to be involved in, and they should have something similar. You can run for a board of directors position, volunteer to be a mentor at Legislative Day. I recommend that any pharmacist with pharmacy students attend Legislative Day and sign up to be a mentor, which means that you would take students around with you to visit your legislator, and that's really how they get the most out of the day. So without the pharmacist there, it's a lot harder to have students have a really valuable experience. So I recommend everyone signing up to be a mentor at Legislative Day. You can also attend meetings, including regional meetings, the annual convention, and Legislative Day, like I said. Promote student pharmacist involvement and attendance at these meetings. So not just at Legislative Day, it's just a really big one that students generally go to, but also at regional meetings and the annual convention. And then I recently also had a student just come to MPA to shadow us for a day during her community rotation, and I thought that was a pretty cool idea as well. So any preceptors on community rotations, have your students come and shadow us at MPA just so that they can learn what a state association is all about. And she also was required to attend a Board of Pharmacy meeting. So that was actually really, really interesting for her. She found both of the experiences very valuable. There's also national pharmacy associations. There's APHA, or American Pharmacy Association, NCPA, National Community Pharmacy Association, ASHP, And there's pretty much an association for every practice setting of pharmacy. The most important thing you can do is get to know your legislators. So relationship building is our most important asset. There's our federal and state legislators, as well as representatives and senators. We have our federal issues. So provider status would be like a federal issue, and then our state issues like a PDMP, because we're the only state and territory in the U.S. without one. Currently, legislators are campaigning before the November 6th elections, so it's a great way to start building that relationship, volunteering to assist with their campaigns. Also attending the Missouri Board of Pharmacy meetings. I recently brought a student pharmacist with me to attend a meeting, and his comment after was that he was just so surprised how few people it took to make the choices for all of the pharmacists of Missouri and what they can and can't do and what their practice ultimately looks like and where it's heading in the future. Learning assessment question: what is a national and state level issue that all pharmacists can get involved in? A, immunization authority, B, provider status, C, statewide prescription drug monitoring program, or D, managed care Medicaid? And I'll give you a hint, it's not D as in dog this time. It is B as in boy, provider status. Immunization authority is really a state level issue, as well as the statewide PDMP and managed care Medicaid. So the only real national and state level issue is the provider status one. What is Missouri lacking that all other states and U.S. territories have? Statewide PDMP, A, B, prescriptive authority, C, PBM transparency legislation, or D, all of the above? And the answer is A, a statewide prescription drug monitoring program. Although we do not have prescriptive authority and we need better PBM transparency legislation, other states don't necessarily all have this legislation, so a statewide PDMP is the one that everyone else has that we don't. If you have any questions, my information will be on the next slide, but please refer to the handout for more detailed information on the Senate Bill 826 and the Missouri Board of Pharmacy rule changes from this past year. And again, I'm Annie Eisenbeis, the Executive Fellow with the Missouri Pharmacy Association. My email is mentioned here, Annie@morx.com. And thank you so much for joining me for this webinar today.